live here. Just want to confirm we're on Facebook. Where are we? Where are we? Okay. There we go. Got a couple people joining the room already, which we love to see. Let's not keep them waiting any longer. Hello, everyone. Welcome back to the first Luncheon with the Experts of 2025. I'm just now getting over the point where you're writing the previous year on the dates on your papers. This is a Carcinoid Cancer Foundation and LACNETS program, and yeah, it's been a little while. I mean, just early December, I think we had the last show. My beard has come in a little thicker. I don't know how long this will last, everybody. But yeah, the time is clicking away. So I am excited to be back. If you don't know me, my name is Rain Bennett. I'm a filmmaker and a writer. I've been working with CCF for over 10 years now. I think 12 or 13 years. It keeps getting bigger, that number. I don't know why. And I've been working with LACNETS for a good portion of that time as well. And in that decade plus, we've created all kinds of video content, hundreds of videos, maybe even more. Live video series like the one you'll watch today, patient-centric documentaries, treatment-based, like, dense informational videos, but all with one mission in mind, and that is to spread awareness and education about neuroendocrine tumors. That is what we are here to do. Now, in my opinion, first of all, if you're new to the show or new to this journey, I want to say welcome. And in my opinion, very strong opinion, the value that this show provides is twofold. One, the information that you'll get from our guest expert, and two, the shared support, the shared stories from within the community. I talk about it so much. The community is something that impresses me every day, every week, how supportive it is. That includes doctors and specialists, that includes advocates, that includes, of course, patients and caregivers. So if you are new to this community, you can see the chat section, reach out, comment, say hello, introduce yourself, embrace the community, and I assure you they will embrace you back. So do that. Let us know where you're signing on from the world. You can see people are already starting to do that. I love to see how far these programs reach, and a lot of people join live, even though it may be midnight their time in the world, which is a testament to the value of the show. It makes me very proud. Before we get going, one of the main things that the merger between CCF and LACNETS has produced is the support line for those affected by NETs. So to receive support, whether a patient or caregiver, you can go to lacnets.org/support line, fill out a questionnaire there. And they will give you help and the guidance that you need. And we'll add that link in the comment section, as well as any links that we refer to today or our guest refers to today. So speaking of our guests, I am excited to welcome back to the show Dr. Namrata Neena Vijayvergia. Dr. Vijayvergia, welcome back to the show.
Thank you. Thank you so much for having me, Rain. It's a pleasure. I know, and even more honored that we're starting off 2025.
That's right. You're going to set the bar super high for the remainder of our guests. And we were just talking before we started recording. You've been here several times. Neither one of us knew the exact number, but you're no stranger to the show. But for those who may be a stranger to you or to your work, and I know you have a little bit of a new position, tell the people listening what your role is in this neuroendocrine tumor community that I alluded to. Where do you work? What do you do?
Well, I'm just a piece of the puzzle, right? We have neuroendocrine tumor treatments, and awareness is a very important and a dear thing to my heart. I work at Fox Chase Cancer Center in Philadelphia. I have been in practice for 9 years now. I also trained here, started doing neuroendocrine tumors from my fellowship, and then just continued to work, learn, and gain more experience and do research in this space, because I really feel that neuroendocrine tumors are a very unique group of cancers, and our patients are a very unique and a very special group of patients, that it is so rewarding to take care of neuroendocrine tumor patients in various different ways. Like, you trying to treat the symptoms, right? You give the patient a somatostatin analog, and then the diarrhea is first time better in 10 years. It is very gratifying acutely. And then we have long-term relationships with these patients, and the continuity and the relationships we develop with our patients is really unique and very different. I also do a lot of, there's two big cancer types I work on. It's neuroendocrine and colorectal cancers. And that's the difference that I see. The continuity that you get with our patients is really very special to my heart. There's a lot of exciting, research stuff happening in this in neuroendocrine tumors, lots of new drugs. So it keeps it, I'm very excited to bring them to clinic for our patients. So it's pretty cool. More recently, I know I've been promoted to the interim chief of our GI division, which is new role. Obviously, definitely grateful to God and to everybody who thought I was worthy of it. But yeah, new work, new challenges.
I thought you were going to say to all my haters that doubted me. Um, that's amazing. Congratulations, by the way.
Thank
Very,
you.
very deserving. I love your passion about the work that you do so much. It it is evident every time that we talk. Folks at home, really quickly, go ahead and start sending in your questions. I saw someone from New Zealand, Sonia from New Zealand. Exactly my point earlier, right? I'm not sure exactly, Sonia, what time it is, but I know it's not 12 noon like it is where I am. I have a question
4
for
a.m. there, actually. It is right now. My
um,
brother lives in Australia. That's why I know.
Oh, got you, got you. I have a question for you, and you said the word relationships, and I love that because the question was already kind of percolating in my mind as you were talking. So I'll use your word there because it's so perfect. The relationship between the patient and the doctors in this specific community. And I don't want to put words in your mouth, but this is something that I've heard before from other specialists and doctors in this space. Can you talk to me a little bit about the value of communication from the patient to you? Like, I, I'll say what other doctors have said, like some version of, and I'm very much paraphrasing here, like we learn or we get as much from them as they get from us. That's kind of where I'm driving that.
Mhm.
I don't want to like wedge you into that, but just talk to me about the value of their side of that relationship because generally, and I'm
Mhm.
also, speaking for maybe people that I shouldn't, but generally you think the doctor tells the patient what to do. We are the source of information. It's a one-way street, right? And you see where I'm getting. Can you talk to me about the value of that
So I think
two-way? Yeah.
the reason, right, that why this two-way communication actually amounts to much better treatment for neuroendocrine tumor patients is because it's a rare cancer, right? It's a rare disease. You don't see it as much, right? I work in an academic center. I have more patients concentrated that come to me, but in general, when you go out to a doctor, there's not a whole lot of patients that they see with this disease, and sometimes the patients are actually more educated than the providers about the disease because of all the it's
Yeah.
their disease, right? It's your disease. You're the one who's most invested in it, and you bring your doctor to invest in yourself with it, and we learn along the way too. And that is the biggest most important thing, why patients being part of their care makes this disease a much more interesting and a much better learning experience for the whole team, not just the provider, my nurse. Trying to get a patient who calls in with diarrhea, like, not fortunately, my team knows about all the nuances of it, but there might be, if someone's calling for diarrhea and you're not just dismaying them as, oh, just take Imodium. There are drugs which are specific for this disease. And when patients ask, then you physicians are like, or the team is like, oh, let me look into that, let me read about that, and it helps for much better care for the patients. As I said, coming to the same point, we learn as much from the patients as patients learn from us. There is a lot of questioning about, there are some new treatment options that are out there, right? We have BRRT, we have pills, you have, like, TKIs or different kind of medications for it. We still are trying to figure out what is the right sequence of treatments, and one size doesn't fit all at this
Mhm.
point in time. So that's where the patient input is very, very important to fit the right size for my patient, right? I could have a way of doing it, but nobody knows exactly what is the right sequence of which
Right.
drug comes before that. It is a very individualized decision. And how do I make an individual decision about a patient is bringing the patient into the discussion, right? That's
Mm.
the only way I can individualize it. And that's why it's so important to hear what the patients say. What, like, I just had a patient this morning, not to mention, they deciding we should we do everolimus, or should we do cabozantinib, or should we do some other drug. They have high blood sugars and they brought it up. I was like, oh yeah, I forgot about that part, right? It's just we work together to make the right treatment decision for our patients, and the patient input is very much valuable to make sure, because our goal is common. We both want our patients to do better, and the patients want to feel better, and then we work together towards it.
That's perfectly stated. Much more eloquent than I was. But you got exactly where I was trying to go with that, and I appreciate you explaining that. Makes a lot of sense. And you mentioned sequencing. That's something that comes up on the show a lot. Also something that I'm very interested in. I always tend to ask questions about that. I know it's very much under discussion and debate, but I think your point is super valid. Of like, yeah, that's because it's very individualized. Like,
Absolutely.
and that goes back to the communication between patient and provider. Folks, real quick, we got some questions coming in, so I'll go ahead and pivot to those. But just to guide you a little bit in those questions, really hard to field in this format when you're not one on one with Dr. Vijayvergia. Super long, super dense. Case specific questions. So try to ask them in generic chunks. Dr. Vijayvergia may ask you for clarification on something, and then you can always chime back in, and you can always ask follow up questions. So there's no limit to questions. We're going to try to get to them all, but that just helps us, in this format where I'm reading a question and all of that. And again, it's hard to really get super case specific in this format. So our goal is to like get you further down the road and to keep getting you further down the road until you can get to that exact answer you're looking for. So let's go ahead and start taking some questions. We have one that comes in from Shane. Shane, who's always a great question asker, by the way. Hey, Shane. From time to progression to actually starting PRRT, which you've just mentioned, is it common for a month to go by to get the ball rolling? If so, how does a doctor rule out growth that might have happened in that 1 month time period versus failure of PRRT? Great question.
Very good question. I think it's the logistics of trying to set up PRRT, right? Trying to get approvals, time, meeting with the nuclear medicine doctor, meeting with the radiation or whoever is doing it in your center, trying to order the drug requires 2 weeks notice to the company. All of these things definitely lead to about a 4 week lag of when you decide you want to treat to actually get treated. Now, typically, neuroendocrine tumors, most of them, right, are the well differentiated neuroendocrine tumors we're talking about. Their growth rates are not very fast. So you don't see them growing like, that in 4 weeks. Typically, like if someone has like pancreas cancer, colon cancer, if we have, treatment delayed by more than 4 weeks, we typically want to restage them before they start treatment just because they grow very fast. But when you come to neuroendocrine tumors, because these cancers are, how we call them, these are cancers, but sort of in slower motion, because, especially with the well differentiated neuroendocrine tumors, when that happens, the 4 weeks is not enough time for it to grow significantly to see a difference. So we typically believe that 8 to 12 weeks, if it's been more than 8 weeks since you've had your baseline imaging or the previous imaging done, I tend to re-image a patient, not 4 weeks, just because these are slower growing cancers. So that time limit of 4 versus 8 changes, and we don't expect too much things to change in the 4 weeks, if that
Got
makes sense.
Got it. Thanks, Shane. We actually have a follow up question from Shane that says, "Can dying tumors cause discomfort during PRRT?"
Great question. So the way PRRT would work is, right, it is radiation being delivered to the tumor cells directly, right? So it's like basically, the beta particle goes in tumor, it causes cell death. And when that happens, there happens some degree of inflammation that can come with it, right? Inflammation is just like, swelling in that area, you could say, in the where the tumors are. And sometimes that swelling can cause, that dying cells can sometimes produce a little bit more of the hormone. So some patients who have symptoms from like diarrhea may feel that their symptoms are slightly worse initially after their initial PRRT. And sometimes I have had my patients who complain that their pain actually got worse before it started getting better. So that could just be that initial inflammation in the first like 1 to 1.5 week after you get treated. Sometimes I've had given patients some steroids to decrease that inflammation to help that pain.
Got it. Thank you. Question from our friend Pat. Hey, Pat, is Fox Chase using histotripsy as treatment for NETs? And
We have,
also,
yeah. Oh, sorry. Go ahead.
no, I was just saying, also under a lot of discussion these days.
Absolutely. So we do not have histotripsy at this moment. We are working with the company to see if this is something we can bring in for our patients. I think it's a very new technology. The data is very exciting, but we really don't have all the strongest prospective data that we need to say that, oh, like if I'm not treating somebody with the regular ablation versus histotripsy, is how much significantly better it is to, it's just we don't, we're waiting for that data to come up. But nonetheless, I think this is an option for future. We don't have it at Fox's at this moment, but we are in the works of deciding. We're following this data very closely to see if at any point it says that, oh my God, it is like so much better, we have to bring it in. And we're working towards that.
Got it. Next question from Josh. Josh says, "Hi, I have no nets showing on any scans. Have had all the scans available. Positive blood tests from Ren Laboratories. That's the net test. I'm having many symptoms, and I'm on the month octreotide injections, month 4 now. My question is it common to have cold hands and cold feet most of the time? Also, I have always have difficulty getting a full breath and have stuffed sinuses. So the question is this a symptom of carcinoid syndrome? Would the issue perhaps indicate NET in the lungs, or could it still be available somewhere else?" So a few questions in there. Let me know if you need me to repeat anything.
No, I think it seems like you've had all the testing done, right? So,
Mm-hmm.
which is a good thing. We don't see anything anywhere. That's a really good thing. I know the positive, the Ren Laboratories test, which is basically a test to see. It basically gives out a score. It takes the blood sample of a patient, and then they look at special genetic, like cancer related genes in the blood, and that's how they come back as like if it's positive or negative test, and it gives you a risk score as to what is the chance that you have still cancer left or not. So it's a newer test. Again, it is no test is 100%. So I'm hoping that I really hope for your sake maybe it's a false positive, that which means that you still don't have disease, but you see the positive result. But it's a very sensitive test, and that's why your doctor should very closely follow you with imaging to see if maybe there is some cancer and it's so tiny we cannot see it with scans. So we typically just follow patients more closely than we otherwise would in a situation like this. And if the next question about your symptoms, cold hand and cold feet are it's a very interesting symptom.
Right.
It is not, I see it in a lot of my cancer patients, not just neuroendocrine patients. And I think it's related to some autonomic, like basically your nerves, you could say, like not just nerves, but basically when you stand up, you have some special hormonal release that make your blood pressure go right. And all of these changes can sometimes lead to different responses to the
Mm-hmm.
cold. So I don't think it's directly related to the neuroendocrine cancer per se. A lot of people have it. I have it personally, but it would be interesting. As I said, no patient reads the book, and your symptoms are very different than someone else's. And if this is something that is like temporary related, right? You had the cancer when you had the cancer, you actually had the symptoms. They got better when you stopped, when the cancer was resected. Now it's coming back again. Those are, so we have to fit the story with a symptom. So just that particular symptom by itself doesn't raise red flags, but the whole story may, and that's something you may want to discuss with your doctor, right? The question of the stuffiness and like breathlessness that you talk about. So neuroendocrine tumors sometimes just produce hormones that can cause mimic asthma-like symptoms, right? That can happen. It doesn't have to be like, obviously tumors that arise in the lung are more likely to do it, but it doesn't have to be. It could be hormone from any area that can give that symptom. But but you had a scan, and lung nets are very well visualized on scans. If you have a neuroendocrine tumor in the lung, it's very hard to hide it. And if the scans are good, I'd suspect that may not be the case for you.
Got it. Hey, thanks, Josh. Appreciate your question. And this for Josh and anyone else. Always let me know if there are follow up questions that you have. Next from Heather. Heather says, "How common is it for the carcinoid to impact a patient's heart, and is carcinoid syndrome always involved in that case? How can carcinoid involvement be confirmed if that's even possible?"
So, good question. It's actually a very important question. And this is an area that we are trying to raise awareness in oncologists, in cardiologists about this problem that can be associated with neuroendocrine tumors. So, in general, about 30 to 40% of neuroendocrine tumors produce hormones. They are hormonal symptoms, right? They have carcinoid syndrome. The specific hormone, which is the serotonin, can go and damage the heart valves in people, right? It can, long standing, can cause damage to the heart valves. Now, most of the time, you have the same serotonin hormone also causes diarrhea. So most of the time, you have diarrhea, flushing, long standing, and then there's a risk of developing carcinoid heart disease. But it's not always the case. many times you can have the serotonin hormone being elevated and can cause silent damage to the heart over years, but you have no symptoms or no diarrhea because it picks and chooses. Every human being is different. It's not written in stone that everybody whose serotonin is elevated is going to have diarrhea. It just doesn't happen that way. I have so many patients right now who are in that category. So what we tend to do is it is indicated that for every patient who gets diagnosed with a neuroendocrine tumor of the small intestine, that's where the serotonin is most common. And if the cancer is spread, like in that situation, we should always check the baseline level of the urine 5-HIAA or the blood 5-HIAA, which is a blood test or a urine test, 24-hour urine test that they do to look for the breakdown products of serotonin, and whether you have diarrhea or symptoms or not. We should always check that. If that is elevated, so if you're a serotonin producer, I tend to screen for heart, for the echo, doing an ultrasound of the heart to make sure that the heart is fine, and then repeating it every 2 to 3 years. Or if new symptoms develop, we keep a close eye on it.
Got it. Thank you. Thank you. Question from Jim. It says somewhat similar question to the previous one, I believe. If on lanreotide for 3 years, is there any relation to higher potassium levels?
Lanreotide by itself should not lead to high potassium levels. What I can think of is, if some people get diarrhea and you end up taking a lot of potassium supplements with it, and then you start the lanreotide, the diarrhea improves, but then the patients don't back down on their potassium supplements, be it food wise or anything, can sometimes your potassium level may be elevated. But typically, lanreotide by itself should not increase your potassium levels.
Got it. Thank you. Question from Rachel, I believe. Let me know if I'm pronouncing that correctly over on YouTube. And by the way, folks, we are streaming to YouTube as well, simultaneously as Facebook. And I say that because I spoke with someone yesterday in the net community that didn't have Facebook. And there's a lot of people that don't, or people that have chosen to leave Meta for whatever reason. So if you know someone who would still benefit from this show and they prefer YouTube and Google's team, yeah, let them know that we're going there too. So sometimes I forget that there might be a population of people out there that just prefer that. And if they don't know, then we're not helping. So anyway, Rachel says, who should I talk to for guidance about my immune atrophic gastritis and gastric carcinoids?
Yeah. So neuroendocrine tumors in the stomach or the gastric carcinoids are of various type 1, 2, and 3 is what we call it. What this viewer is referring to is the type 1 gastric carcinoid. And these basically happen if the lining of the stomach is sort of attacked by your own body's immune cells. So that's the atrophic gastritis. And when that happens, you cannot produce as much acid. And when you don't produce acid, your pancreas senses that and then comes back with the hormone gastrin and tells the stomach, hey, wake up, produce more acid. But it cannot because the lining is damaged. But that gastrin sort of stimulates the neuroendocrine cells in the area to make tiny, tiny, small tumors, which is the type 1 gastric nets. Now, typically, the good news with this is it's not a majority, or pretty much all of the time, these tumors are just localized, tiny, tiny tumors that we don't tend to metastasize. They don't spread. So as a result, what we typically do in this setting is you cannot regenerate the lining of the stomach. You cannot take the pancreas out. You need the pancreas for all very other important things. So what we do is, as and when these tumors appear, you just basically do endoscopies once a year on patients, and if they get these small tumors, once they grow over a centimeter or above, then they just like snare it out, or they just take it out. So that it doesn't interrupt, it doesn't bleed and cause problems to people. But it doesn't, like, typical cancer like things, that we worry about spread or going to other places. That doesn't happen with type 1 cancer. So we just tend to just repeated endoscopies, and resecting when they get slightly bigger is the typical way it's managed.
Got it. Thank you. Let's see. Next question comes from Lynn. Lynn says, my dad has carcinoid tumors in his liver and has been given Y90 and 2 TACE treatments in the beginning 9 years ago and started monthly octreotide injections. Main symptoms have been flushing and only sees diarrhea and vomiting when he's in crisis. Seems like it occurs just before the monthly injection is due. How often do you use octreotide injections, and can they be given every 3 weeks instead of every 4 to prevent this?
So Absolutely. This is called the breakthrough effect. You may have heard. I'm it's grateful that he doesn't have a lot of diarrhea. People also suffer from that too during the last week. And there are various ways but how we handle it right now. So right now, if somebody presents with the breakthrough symptoms, we have the option of, if it's just like a day or so and randomly they have a little bit more, we can give patients like a short acting octreotide. It's basically the same shot he gets, there's given in the buttock area. It's a short acting version of it, which lasts for about 6 to 8 hours. And we give it to the patients. They can use it 3 times a day if needed. It's just like an insulin needle. So it goes under the skin and it comes in like 100 microgram, 200 microgram doses. And that just helps go through that time. The other option is we can move the shots to every 3 weeks. Now that requires us to get approval from insurance. It can be done. We do it it's mostly done. It cannot be done for the lanreotide. There is safety data for octreotide that it can be given every 3 weeks. And also, we can if it's octreotide, we can increase the dose from, like, if the person's getting 30, we can sometimes increase it to 40, or even like very rarely 62. And typically, so those are like the different ways how we handle it. There is, if they have diarrhea, there's a pill called Zermello, which your father doesn't have, but that's something as an option. As we move forward, we're really hoping that we will have an oral alternative to octreotide, and that is a pill alternative. And if those studies actually come positive, it's going to take a few years for us to know. But then, there's been an option. There'll become a day where you can just take pills every day, and that will not have these breakthrough issues.
Gotcha. Thank you for your question. Quick question from Pat again. Is there another test out there similar to the NET test?
So the NET, both NET test and the REN laboratory, these are two different tests.
Oh, are they?
So the NET, RENS is the NET. The NET test itself is the REN laboratory test. There's also another test which is called the PPQ test, which is one done for PRRT testing. Now, both of these are very investigational. So I want to make sure that people don't take out of this that they go and ask their doctor tomorrow to get this test for them, because these are both investigational tests, as in these are tests that have been developed. Again, we just talked about it. They look at, if there's like cancer genes, and they look at the genetic changes in the blood, trying to understand if there's any cancer cells left and give you a score of risk score. But we don't know how to interpret it as well at this time in prospective studies, which means once we get the result, like, we don't know what to do next, right? We don't know. We're still treating patients based, if we see something on the scans, we do something about it. If patients have symptoms, we do something about it. Just that test itself is not able to guide our treatment right now, because it's very early in its development. So we need more data to be able to use any of these tests in our clinical practice. And I want to make sure that people understand that.
Yeah, that seems to be the consensus from our guest. And Robin, you have a question a little bit further down about that. You wanted more information. Hopefully that helped answer some of that. But if we didn't quite get to your question, let me know. Also, this is for Robin or anybody else. I mentioned at the top of the program how many videos we've done. We've been doing this show specifically for 5 years now. And the very first episode, I believe, which would have been back in 2019 or 20, was with Dr. David Maudlin, of Wren Laboratories. And so, Robin, I would direct you there to ask more information about that, or of course their website. But we had a whole luncheon with the experts, so an hour-long, Q&A with him then, if you want to hear straight from him. But a lot of people are interested in it.
Yeah, it's very exciting, right? There's a way we can improve our testing, because our current blood tests are not the best in general. But nonetheless, I think, we just need to learn, because they teach us in medicine, don't order a test if you don't know what to do with the results. So that's a very important thing, right? You order a test. If I don't know what to do then with the results, it makes it very difficult to use that test appropriately. So we're trying to learn that better as time goes on.
Such a great line. Like that's life advice. That's business advice too. Don't order a test if you don't know what to do with the results. It's so good. It makes a lot of sense. Folks, if you joined us a little bit late or just joined us recently, this is Luncheon with the Experts, first episode of 2025. We are here with Dr. Neena Vijayvergia. The numbers keep on growing on YouTube and Facebook, so that's what we like to see. Great questions. Let's keep it going. We got about 30 minutes. Broad question here from Lorraine. What are the side effects of PRRT? Common question, though.
Absolutely. And definitely, I think, there is no free lunch in medicine. Like you're right. That is the problem with medicine in general. Everything comes with a baggage. And that's why we have to be very careful when we have new treatments. Anything that new that comes in, you want to make, you want to, the risk and the benefits need to be compared between them. So yes, benefits of PRRT, it's a very effective therapy. It's a targeted way of giving radiation. In big studies, there's an 80% reduction of cancer growing, all good things. But then if you look at the, what are the negatives that come with it, I would probably say the most common one that come in the short term are some fatigue, some tiredness that patients feel, sometimes thinning of the hair. Like, that's something that I've seen. A lot of patients complain, report of this. Rarely, like in patients who have a lot of carcinoid syndrome symptoms, it can exacerbate those symptoms acutely. Same with the pain, as we were talking about. So these are mostly the acute problems. Now, what it can do is the radiation, basically, even though it's very targeted, still can get to your blood cells and your kidneys. Those are some longer term things that we worry about. And because it can get to your blood cells, it can bring your blood counts down. So it can cause, your cells that actually produce your blood cells are very sensitive to radiation, and any amount of tiny radiation can stun them a little. So they can bring your blood counts down a little bit. And that's why before every treatment, you get tested for the blood counts. And we have specific limits that if your blood counts are below a certain limit, we don't want to treat you again, or we want to treat you at a lower dose, or delay treatment till give your blood cells time to recover fully for that next insult that comes in, right? So that's more common. Most of the time, these numbers, we with these adjustments that we do are, you're able to get your treatment, and then with time, these numbers recover to normal. But sometimes, in less than 5% of the cases, that damage, that stunning to the blood cells that we talk about, the precursor blood cells, can be more than just a temporary problem. There's a risk of developing something called myelodysplastic syndrome, less than 2% of the time, and really 1% or less risk of actually developing a full-blown blood cancer. That's a very, very small risk, given the whole, scheme of things, right? We have all these benefits. We got to worry about the cancer we have, or worry about something that may or may not happen in future. But in the end, like, that is a risk that we have to take when we're trying these therapies. The other one is because the kidneys have a lot of receptors, we give people a protein solution to sort of protect the kidneys from the side effects. But sometimes, some of those sucker radiation bugs go there, and then they can cause, affect your kidney function a little bit, in the sense that if you get it and then you're living, 5, 10, 15 years from now, at that point in time, those slightly lower, everybody's kidney function, gets worse with age. We all, like, our kidneys cells one by one get worse with age. And then if there's this added insult, you can see it's slightly more than you would see as normal people's numbers do. So it's very small risks. I don't think the risks are a lot, but there are some. And that's why we have to be very careful as to who we offer it to. It has to be the right patient, and that we feel that the benefits way outweigh the risks. And for most patients, it does.
Got it. Thank you, Lorraine. Appreciate your question. Next question from Melissa. Melissa says, can NETs cause peripheral neuropathy, or can octreotide or other targeted therapy cause neuropathy to worsen?
It has not been shown. It's not a common problem that NETs cause neuropathy. What what has been shown sometimes is that they can cause bony metastases, so the cancer spread to the bone, and the bone sort of, like, the tumor grows and presses on nerves, which can lead to, like, a neuropathy of one area or one leg, one arm. But the symmetrical peripheral neuropathy that we hear from other cancer drugs is not something that is typically seen with neuroendocrine tumors or its treatments per se. But having said that, I have seen everything. I've actually seen a patient who definitely had neuropathy, and then once we started treating their patients, that they got better. And so everything, human body is so different, and no one human reads the book, right? You don't read the book, cancers don't read the book, and everybody is so different. The whole story tells us the picture and helps us go back and look like, oh, that may be the case. We never know.
Got it. Thanks, Melissa. Appreciate you and your question. Next question from Jamie. This is an interesting one. I work as a provider in occupational medicine. Over recent years, there's been more of a focus on occupational related hazards, specifically in firefighters related to PFAS, PFAS, among several other chemicals. It seems that there have been increases in both neuroendocrine cancer and neuroendocrine tumors in this population, including my husband, who has been a firefighter for 24 years, diagnosed recently with a rectal NET. Is there any research that you're aware of, or specifically to occupational hazards in firefighters, that can contribute to this? And does ongoing exposure increase risk for reoccurrence or poor prognosis?
So I don't know the answer to that question. I wish I did, and it's a great question to
Right.
ask. Obviously, we don't know what the environmental exposures do. We do know, incidence of neuroendocrine tumors has gone up. Is it we all chalk it up to better diagnosis and more testing? But there could be environmental factors that are unknown, and it's a great observation that you make. It's something to look into. I don't think there's data at all at this point in time to suggest one way or the other, right? So it could be true, it could be false. I do not know the answer to that
Yeah.
question. Having said that, the incidence of rectal neuroendocrine tumors has gone up mostly because we are doing more and more colonoscopies. Many times it was happening, we would see patients would have rectal nets, and you would never know because you never did a colonoscopy to find it. And then, so that has increased the incidence of rectal nets a lot.
Mhm.
Same with lung nets, because we do screening for lung cancer with CT scans. But but still, I would probably say that whether there's a correlation with any exposures is a very good question, but an unanswered question at this time.
Got it. Got it. Yeah, I think that's an interesting question too. Appreciate you, Jamie. Let me know if you have anything else for us today. Donna says you mentioned the 5-HIAA test, which can be tested via blood or 24-hour urine sample. Which do you prefer, and for what reason?
See, I would say the test I prefer is the one that's available in your area, and is
Okay.
because they're both equally good tests in terms of their what do you call it, their result, right? The result we get from both of them are very sensitivity and specificity wise are very good. The problem is the plasma HIAA. The benefit of plasma HIAA is it has a faster turnaround time, so you get the results faster, and it's a one-time blood draw, right? Just one blood draw, and you get it, and you get the results. So it is a slightly easier test to do. Whereas the urine 5-HIA is a more slightly more cumbersome test, right? You have to take a jug, you have to collect urine for 24 hours, bring it back to the lab, then they send it out. It's a little more cumbersome. But having said that, it's a test that has been here for a long time, has been proven efficacy over the years, and multiple different studies have shown its benefit. That I think there's more data for the urine 5-HIA, but equally the plasma HIA is supposed to be equally effective. It's a good test, but many places don't have it at this point in time. So it has to be a test that your doctor can interpret, and it has to be a test that is easily available to you to be able to do it. Always remember, both those tests, you have to have dietary restrictions for at least 3 days prior, which are tryptophan rich foods should be avoided. And that holds true for both of them.
Got it. Thank you. Um, pardon me. From Rochelle, our new friend from YouTube. Can you determine if your asthma-like symptoms are caused by carcinoids, and if so, how do you manage those symptoms?
The octreotide shot, because the hormones cause those symptoms
Hmm.
to people. So it's the same hormone that causes the diarrhea, and the same hormone can sometimes cause asthma-like symptoms. And the shots, the lanreotide or octreotide shots, should help if it is related to that, right? And also just supportive management of inhaler, those kinds of things help people. But we typically employ our pulmonary colleagues, so our lung specialists, so not cancer, but just lung medicine, lung doctor specialists, to help us understand this better. They can do pulmonary function tests, a special test to evaluate whether this is actually something there or not. So we really rely on a multidisciplinary group to come up with the best treatment for any problem.
Got it. Thank you. Next question from Atif. My original pathology report post surgery diagnosed me as large cell, poorly differentiated NEC with Ki67 at 50%. Another pathology based on the original tissue from surgery indicated I might be well differentiated, but still high grade. Is this some subjectivity playing? Should I try to resolve the differences, or is it basically the same since I'm is it all the same since I'm basically high grade?
So it's not exactly the same.
Okay.
There's a huge debate that is going on even in the scientific side about how we can best differentiate between a well differentiated high grade neuroendocrine tumor and a poorly differentiated neuroendocrine carcinoma. So the large cell neuroendocrine carcinoma is a poorly differentiated tumors. You know, they have under the microscope, they look poorly differentiated, don't look like neuroendocrine cells. The well differentiated neuroendocrine tumors look like neuroendocrine cells. But sometimes there's, not easy. It's, as I said, what nobody reads the book. Sometimes it's very difficult for pathologists to evaluate. So then we actually sometimes, revert to doing some molecular testing on the tumors. The molecular makeup of the poorly differentiated large cell neuroendocrine carcinomas is slightly different than the well differentiated ones. And I really, think it is useful to go to a higher center who has to sort this debate out so they can look at both pathologies for you and actually give you, because I think you have one. It's sort of not, I don't think you have two different things going on. It's just one, and to sort out which one you have, is it the well diff or the poorly diff? Because well diff G3 net, Ki-67 50%, got in future and PRRTs and all these drugs are options. Poorly differentiated carcinomas, PRRT doesn't do anything. So it's important to find out what exactly your diagnosis is, for preparing for future. Hopefully you won't need anything ever again, but just important to know what your right diagnosis is, because the treatments and observation and even surveillance changes based on that.
Got it. Thank you. Thank you. Next question from Debbie. Debbie says, I had tumors in my spine and bone in my right arm. I had 7 months of CAPTEM chemo and my bone mets have gone. Have you ever heard of this?
I never say never in medicine again. Like, I know it's like cliches that I'm talking about. It's not common, but it's not unheard of, right? Even in the clinical trial with CAPTEM, there was a small single-digit percentage of patients who had a complete response to the treatment. So they give the treatment, and you are fortunate, God's on your side, and you had a really great response to it. And it's not common, but it is not unheard of either. So congratulations.
Yeah, agreed. Thanks, Debbie. Speaking of trials, Chris says, I'm participating in the new Alpha trial, RYZ 101. Do you have patients participating in this, and what are your opinions on it?
So I'm actually part of the study, so I cannot tell you my opinions because it'll be a conflict of interest. So I'm going to stay away from that. But I have patients parts. I didn't open the study at my center per se, but I sent our friends across the town. They have it, so I send all my patients to her, and then we do it together. So absolutely, it's a very important study that is being conducted.
What information can you give us about it for those who may not be familiar with it?
Yeah, absolutely. So the Raise Bio study is it's Action One study. It's called. It's basically for patients. It's a new kind of PRRT. So typically with the Lutathera or the lutetium dotatate PRRT that we all know and is approved, it's the type of particle, the radiation particle you get is the beta particle. Now this is alpha radiation. So it's actinium-225. That's the compound that's used. But the alpha radiation tend to have higher energy and have less depth of penetration. So think of it as like, so if they go on the cells that have the receptor, they'll deliver more energy to those cells, so better kill. And because they don't penetrate too much, we hopefully will have better toxicity profile. Now, it all needs to be proven. This is the science behind it, right? The science says that could be the case. In humans, how it's going to work, the studies are going to show. So the Action One study is for patients who've had PRRT before, and then if it's more than been 6 months to a year since they got diagnosed, like the response to the first PRRT was at least 6 months to a year, then you want to treat them again with PRRT instead of doing the retreatment with PRRT, which we sometimes do for 2 cycles. This study is trying to study, that is also a study, by the way, but this study is trying to use alpha PRRT with actinium-225 and the patients get randomized. There's a 50-50 chance you get the drug, and the other 50% would get standard treatment, like some of the other treatment options for these types of tumors. And we want to see if one is better than the other. That's the whole point of the study.
Got it. Thank you, Chris.
Not for the other study, right? The retreatment study that we were talking about. So basically if somebody, right now what we do is if someone got a really good response to PRRT, what we can do is, if they recur, the option of doing 2 more doses of PRRT. We had some data from Europe that it may be good. We're actually doing a study in US, Dr. Aman Chauhan, who has been a part of this conference too, but he's actually leading that study where they're trying to study that we just do 2 more cycles of the PRRT in patients and see how patients do, to give us data so we can tell patients when offering this therapy that, hey, this is the relative benefit we expect. These are the risks that we know of. or risk from this treatment. We would only know these once we do the study. It's called the NET retreat trial.
Yeah. Coincidentally, we have a question about that, Lynn says, which that may be your response to it, but she had PRT 7 years ago, right after approval, and have had growth again in the last year, and it's been recommended for her to have it again, 2 treatments, and wondered if you would recommend repeating. She's had this cancer for 18 years.
No, this is a very reasonable thing to do, which we consider in patients. Obviously, how you responded to the first treatment, which it seems like you did very well. And then what are the side effects? Would you have residual low blood counts or not? What your kidney number? All of these things play into the picture. And if you're a candidate, definitely an option. See, ask your doctor if that study is open around your area. You can even participate.
Lovely. Thank you, Lynn. From another Lynn, without an E. How does my family member get gene testing as a close member has MEN1? Can't get an answer of how to get gene testing, and I'm just kind of brushed off. I'm sorry, Lynn. That's frustrating. Let's talk a little bit about MEN1 and how one would get gene testing.
Yeah. So MEN1 is a syndrome which can predispose people to developing neuroendocrine tumors in addition to other cancers, pituitary and other tumors, parathyroid and other tumors too. Now, what it can do is because it's a tumor that is actually it's a genetic change that runs in families sometimes, so there's a genetic risk for it, right? So if somebody got diagnosed with MEN1 and has the gene specific for that, it automatically, like everybody who's the first degree relative for that person, should be able to get testing based on those results. The way to, if you are concerned about yourself, the way to do it is, find a risk assessment program, a genetic risk assessment program in your area. That's what if you don't have an oncologist, but if somebody has an oncologist, they can ask them, or your friend can, or your cousin can ask their oncologist for a risk assessment program in the area. And you can go in with your cousin's results, and they will do a pedigree analysis and see if you will qualify for testing or not. And if you do qualify for testing, they'll apply for insurance to get approved and then test you. So that is the way to get it done. You can get a referral for a genetic risk assessment from your primary care doctor based on your results from your cousin too.
Got it. Thank you. Next question from Susan, which is common and a frustrating situation. I have an 8 millimeter pancreatic net, and I'm on a watch and wait. Have not had a biopsy and only a CT dual phase pancreas scan at 6 months follow up. What exactly are we waiting on? Is the question, and should there be other scans or labs being done?
I know that is a very hard thing. We think for us it's very easy. Well, wait and watch. That means it's a good thing we don't have to do anything for at this time. But living with cancer is hard, and I get it. I'm sorry that you're going through this, but let me explain to you what is like the data behind it. Obviously, I cannot talk to your specific case per se, but in general, for pancreatic neuroendocrine tumors, there has been multiple studies, big long-term follow-up studies of patients with this particular tumors that have shown that tumors that are greater than 2 centimeters in size tend to grow and metastasize. So you want to take them out because you don't want it to metastasize or spread, right? Tumors that are less than a centimeter, they tend not to grow and metastasize as much. So it is reasonable to just watch them. And if their size grows, like if they're not following the book, right, by the book, they typically don't grow as much, typically don't metastasize or cause any problems. So if it starts growing and it grows over a centimeter in size and increases in future scans, they may change the plan. So they're watching to see if it grows over time, typically. Because, taking a part of a pancreas out is not an easy task, right? The morbidity, or the morbidity is just a way of saying like the symptoms or the effect of a pancreas surgery can be more disabling than a 8 millimeter tumor that just stays there, and you might just be with it for a very long time. So that is the risk and benefit discussions that are supposed to be having. Like, we educate patients about it and make a decision together. But it is very routinely done that tumors that are less than a centimeter, you just watch them. In terms of the question of other testing, I think they must have, because it's not been diagnosed. I'm sure they did one PET scan for the viewer at some point, because that's how they confirmed that it was a neuroendocrine tumor, because it's an 8 millimeter thing if it's not been biopsied. But if it's avid on the PET scan, then you know it's a neuroendocrine tumor. So that was sort of the baseline that showed that nothing else was wrong. And then in future, you just follow them with the CT, with the pancreas protocol, and the MRI. Those are typically what we do once a year.
Got it. Thank you. Thank you. Folks, just about 10 minutes left. We're going to keep plugging forward and get to as many as we can. Goes by quickly, doesn't it? Sean says, do lymph node biopsies increase the risk for metastases?
Not that I know of. Obviously, right? This is a myth that is like, we worry about that. Can disturbing the tumor, air to whatever, can increase the risk of spread. Previously, there used to be a concern of spread along the track. So where you go in and you biopsy, and when you bring the needle out, can you spread some cancer cells along the way in the track and spread it? Now, unfortunately, that was a theoretical risk, some cancer, but now the development of newer radiological techniques and the needles that they do, when they take the sample, it's basically in an outer core, so it's not even something that can spread or touch surrounding areas. You just bring it out. So that risk is really, the theoretical risk is also gone. You'd still remain the risk of doing a biopsy in a lymph node, and what if you puncture a blood vessel that's next to it, and risk of bleeding and the pain and the infection risk that you can introduce. So that's why we have to weigh the risk and benefits. But when I think about a biopsy, my concerns are not that I'll spread the cancer, more of these other side effects or risks.
Got it. Got it. From Alice. Alice says, I had carcinoid cancer removed from lower lobe in my lung in 2020. Labs, dotatate, PET scan, 4 MRIs since 2025. Showing cancer is back, but the oncologist and other doctors can't find the tumor or tumors. The question is, what can be done for this situation? I'm not sure. Do you have enough information to address that?
I just don't say, like, why do they think it's back? I'm not sure.
Yeah, that's a good question.
Why do they
MRI saying metastasis in spine, but doctor is still unable to find the tumor.
Sure.
Yeah, Alice, if you have any more information or clarification, let us know. I want to try to get you some help. We'll keep moving in the meantime. But Dr. Vijayvergia, your question basically was, what's telling them that
it's like you're saying that the doctors think it's back, but they cannot find it. But then,
I think she's saying the MRI is showing that the cancer is back. The oncologist and other doctors can't find the tumors. Yeah, I'm not sure. Let me know, Alice.
MRI is showing it. We know it's on the spine. So I'm not sure what they're not able.
Yeah.
I'm just a little confused with.
Yeah, me too. It's okay, Alice. We're going to try to get to you. So let me know if you have any other information for us. From Janet, what do you think of the phase 3 COMPETE trial with ITM-11 results? I'm unfamiliar with that.
Yeah, so basically, ITM is another company that is making PRRT, like Lutathera.
Sure.
They have a different. It's lutetium-177, and the protein that they use that binds the radiation to the octreotide is edotriotide. That's what it is. The trade name of that drug is Solusin. Okay, so the COMPETE trial was trying to study if PRRT with this Solusin compound, or you can just say PRRT, is better than Afinitor or everolimus. So we all know that Afinitor or everolimus is one of the drugs that is approved for neuroendocrine tumor management. Here, what they're doing, we also know PRRT is approved. What they were doing, they were comparing these two if one is better than the other. Okay. So the company just put out a press release 2 days ago saying that they met their primary endpoint, which meant that the time it took for the cancer to grow was much longer on the PRRT arm compared to the Afinitor arm. In a nutshell, in a small lay language word, suggesting that PRRT was better than everolimus in their study. Now, we don't have the more details. It was just a press release per the rules of how you present data. They have to present the studies of the magnitude of benefit and everything at a major conference, which they will do hopefully soon, to get us more understanding of it is better. How much better is it? Is it slow better? What are the side effects? What are the comparative side effects between the two? There's so many things that go into that decision, but it's as if it brings back to that first question of sequencing, right? We don't have much data on which therapy should come before the other. this study may answer one of those questions that, oh, if one is way better than everolimus, we probably should try to do that first. Except, it's not a blanket statement, but somehow like that, that's the question it will answer.
Gotcha. Speaking of sequencing, Eileen says, would you use PRRT as a first line treatment rather than an SSA? Or maybe the question is, when would you?
So, the studies for a PRRT with Lutathera in the beginning that came in was in patients who had an SSA, so who had had their shots, the lenalidomide or octreotide, and the cancer grew, and then these patients were getting PRRT. So that's how the first study came out, and that's how we'd been using it until now. But then more recently, there was another study that came out called the NETTER-2 trial, in which in some patients, in patients who have slightly higher grade tumors. So, we know we collect the grade 1, 2s, and 3s. So if you have a grade 2 or higher tumor, which is like Ki-67 more than 10%, like in slightly that we think are more likely to grow faster compared to the slower growing tumors. In this study, patients just got PRRT at diagnosis and compared to starting octreotide, and they found PRRT was better than just doing the octreotide frontline. Now, having said that, the reason why I don't use that as a blanket statement that every patient that comes in, should I give them PRRT frontline? I don't do that because even in the patients who are slightly higher risk, because neuroendocrine tumors are very heterogeneous disease, which means I have patients who have a Ki-67 of 15% and they're 10 years out and they're doing good. And I have somebody who had a Ki-67 of 5% and then their cancer is growing within 2 years, right? So different, even though that it is thought that if you're higher grade, you might grow faster. If you're lower grade, you may grow slower. I really don't think that neuroendocrine tumors follow the book that well in every case. So I have to make that decision on a case by case basis. So we start with the somatostatin analog. You have to weigh the risk and the benefits. We just talked about long term. The PRRT can cause long term side effects. We just talked about that, right? And then if you give it upfront first time and the patient lives 17, 18 years, you worry about those side effects affecting the patients down the road. So you want to see, and I want to know the tumor a little better. And the first time I see the patient, I don't think I have enough know of the tumor to say that, oh, your cancer is definitely on the move. We need to do something more.
Mm-hmm.
So I tend to start with an SSA, and then, if the first scan is in 3 months, like not too long, I don't wait too long. And if things are growing and not doing well, then I know I need to get PRRT. Or if the patient is symptomatic when they present, then we want to do that too. So it's a very individualized decision.
Maybe we have time for one or two more. We'll see how it goes. This is an interesting one. I think is important and kind of big picture. My mother, Shane says, my mother's been living with metastatic pancreatic NET since 2020 September. The biggest progression we've seen followed the passing of her mother and then subsequently the passing of her father. The question is, can grief and stress impact the growth of a cancer like we've seen?
And I wish I had an answer as in like a study to quote to answer that question of yours. I do not, right? There's not that it's not proven anywhere in the literature. Having said that, I am a firm believer that, stress increases the inflammation in the body. And as a result of which, you really, your body's defenses can work on one area. So if you're stressed out, they don't work as well. And I personally believe that stress in not just neuroendocrine, any cancer, patients who are stressed tend to have more side effects of treatment and not really good responses. So I really do think that is something, trying to get help, social services support to make sure that we can, treat healing from outside and inside is important.
Yeah. It's kind of like the flip side of like the nutrition
Exactly.
discussion, right? It's like there's not a food that's going to cure this.
Hmm.
But in general, and again, folks, I am certainly not a medical expert, but in general, being the healthiest version of yourself has got to help. It's not going to hurt, right? Eating good foods, being healthy. I think it's kind of the flip side of that in terms of stress.
And it is true. Like we do know there are studies that have shown that if you have carcinoid syndrome, stress, because it produces adrenaline,
There you
definitely
go.
makes your symptoms worse.
That's a
Like,
great
that
point. Yeah,
definitely happens.
and even some of the comments of Rochelle saying stress definitely makes my symptoms worse. Before we go, Dr. Vijayvergia, I always like to ask, so if someone recently got diagnosed, what's your first bit of advice for that newly diagnosed patient for this specific disease?
I think my biggest piece of advice will be that you really need to know your tumor, right? That's very important. Um, how you are going to do is dependent on a lot of different things. And instead of like, thinking about all the possible outcomes and then dwelling on the worst one, that's what we all do. Whenever it's a cancer diagnosis, life altering diagnosis, we all worry about it. And I totally get it. I would think the same. But it's very important to know your tumor, like you can diagnose, know what kind of tumor you have, learn, read about it, because that will give you a lot of confidence in understanding what's going to come. Treating these
Absolutely.
cancers feels like a roller coaster ride. You don't know what the next step is, and trying to educate yourself can make it a little more like, it's like, watching a YouTube video of a roller coaster before you go on it, kind of a thing of it.
Yeah, I get it. Folks, before we go, I got one big announcement. I talked earlier about the merger of LACNets and CCF. One of the next big projects that we have is very, very big. We're working on, I do these patient documentaries for the team, and I've asked you all about these before, but we are working on a very big documentary project that might perhaps be for television, really trying to pursue that mission of educating people about this disease and making everyone know about this disease. So you can reach me on Facebook. You can find me, Rain Bennett, or rainbennett.com is my website. I'm easy to find. There's not a lot of Rain Bennetts out there, and I'm pretty public with my work. If you know of any patients that have a good story that might be candidates for this is a nonfiction story, so we'll be following real people, real doctors, real patients. Feel free to let me know. I've asked you all this before on the shorter documentaries. You all were very helpful. You can easily reach out to me, like I said, on Facebook or anywhere else online. You can just Google Rain Bennett, and it'll be me that comes up. Okay, stay tuned for information on that. It'll be going on all year. Dr. Vijayvergia, thank you so much for coming back to the show. Excellent job. I really love the way you explain things very simply and kind of like the queen of the one-liners. Like you gave us a lot of these perfect little one-sentence nuggets that were super helpful.
Thank you so much. I really appreciate
Absolutely.
it. Loved it here.
And folks of you at home, as always, we appreciate you being here, and I hope this program helped answer some of your questions. We will be back on a 2-week cadence, but since we started a little bit late in January, we'll be back next week with our next episode, so tune in then. And my name is Rain Bennett. I have been your host. Appreciate you watching, and please join us next time on Luncheon with the Experts. Stay healthy, stay safe, everyone.